Okay. When we talk about assessing uterus, the first thought is, okay, I want to measure anatomical thickness, I want to see the anatomical cavity shape, even if you are interested in assess the vascularization or ruling out pathologies like anemiosis or fibroids. However, the uterus is a muscular organ which needs contractility to perform its correct function. So the myometrium is the muscular layer which contains three differentiated separated strata. The first, the external layer is the subserosum strata, which contains longitudinal layers. The contractions are like this, okay? Then we have the middle layer that is a mixed network of spiral muscular fibers. And finally, the junctional zone is the inner layer which contains circular layers. So we will have in junctional zone circular contraction.
Okay. Therefore, these strata are different. Is the main reason that we will have two types of contractions. Think about that. The strata they have different embryological origins too. So that's why they have different responses. First, the hormone-dependent contractions happens in the junctional zone, and this directly related to progesterone and estradiol levels during menstrual cycle. Meanwhile, the non-hormone-dependent contractions occur in the another two strata, subserosum and vascularis, and they have another embryological origin, and the main function is during parturition. So the contractions are physiological and change through the menstrual cycle, fulfilling their purpose. First, during menstrual cycle, we will have intense contractions going through fundus to cervix to release endometrium. Then in proliferative phase, just before the ovulation, due the effect of the estradiol and to lesser extent to the progesterone, the contractions change, go to cervix to fundus in order to help the sperm to reach the fallopian tube. And finally, in the secretory phase, the contractions become quiet because the progesterone effect to help the embryo implantation. So when it's important to assess the contractions in our field during the window of implantation, because we know the role of these contractions during the trophoblast invasion. We have several studies that associate hypercontractility with less pregnancy rate in our treatments, can provide some indirect information about the function of the progesterone, since the progesterone is a direct inhibitor of the contractions, and the potential treatments can be useful in this moment. So we will have, where is the, I don't have it. Okay, I can show you here. Okay, we will have quiet contractions. I need, sorry, ¿y dónde? ¿Dónde? Second? Okay. We have quiet contractions and hypercontractility. I know at the beginning it's difficult to differentiate between them, but mainly the contractions start here, okay? And they change the endometrial cavity, okay? Meanwhile, here you can see movements from the bowels, even from the external layers of the myometrium, but they don't change the endometrial cavity. So really, when you have seen several contractions or several scans with contractions, you can see the differentiation between them. So why happens? Why we have hypercontractility? We have two main theories. First, because we have a low absorption of progesterone. since the progesterone is the direct inhibitor, as I told you. And then the hyperestrogenism. If we believe in the theory, this is the theory that how the adenomyosis start. And we know that the receptor of estrogen, the alpha receptor of estrogen, can mediate the oxytocin. And as well, it's possible that can decrease the expression of receptors B of progesterone. So it means that hyperestrogenism is possible that can impair the function of progesterone. And in the same way, it's increasing the oxytocin, right? So these are two theories that it's possible that why we have this hypercontractility and can decrease the pregnancy rate of our patients. So I would like to tell you the history, why we are interested in that. Okay, in 2016, it turned out that one of the companies that started one of the antagonists of oxytocin contact us, and they show us how to perform the ultrasound of contractions. So recording a video of 6 minutes, then accelerate it. Okay, so we started that, but finally we didn't participate in this study. Then in 2017, we performed a randomized control trial in which we compared two types of progesterone. There, we decided to assess several ultrasound markers, like not only endometrial thickness, endometrial volume, 3D vascularization parameters, the ratio between endometrial volume and uterine volume, and none of them was associated with the pregnancy rate. The only ultrasound marker that really we saw associated with the pregnancy was the contractions. And we saw that the patients with no pregnancy, without pregnancy, had contractions more than 1.5. And it is already published by Fanxin and colleagues in the early 90s that more than 1.5 contractions are associated with less pregnancy rate. You cannot see the contractions that I show you during window of implantation, but it's established as well because one of the review, the Cluisters review in 2017, that the window of implantation has an average of 0.8 and 1.8 contractions per minute. So in our clinic, we decided to treat first, to assess contractions in recurrent implantation patients, failure patients, because they are the patients that need probably more accuracy in assessing risk factors. And then we decided to treat patients with more than 1.5 contractions per minute, depending on the progesterone levels. If the progesterone were below than 9.2, in this case, we only treat the contractions with progesterone, adding progesterone. If the progesterone was normal, we treat it with atosiban. I'm telling you that because this is when we started the uterine peristalsis assessment. Obviously, there we started in 2D, but playing, suddenly I performed a 4D, and I saw contractions in 4D, and it was impressive for me. I remember this day. And okay, I continued with that. I saw the contractions nicely, better than before, Now you can see very, very well all the contractions, and you can assess the contractions in 2D and 4D. So we carry on with the uterine peristalsis assessment, as I told you, in recurrent implantation failure patients, in 2D and 4D. We assessed at the beginning in these two kind of images. And what we saw is that the 4D ultrasound was associated with the lower quartile of progesterone, but not the 2D scan. So for us, it's like an indirect sign that 4D ultrasound is working better than 2D ultrasound. You know, if it's associated with low progesterone levels and 2D is not, and probably with 4D you can see better because you can see all the coronal view, the 4D ultrasound has indirectly it's better than 2D. Okay, so then last year we published our video article in Fertility and Sterility, demonstrating again that 4D is better than 2D, and the inter-observator reproducibility that it was moderate. Again, the progesterone was associated, the low progesterone levels was associated with more than 1.5 contractions per minute. Again, 1.5, okay? So now, nowadays, we are assessing the uterine peristalsis as follows. First, we are assessing it between 10 and 30 minutes before the embryo transfer. We place the patient in a lithotomy position, and we perform a 3D only to see how is the uterus, because then we need to perform the 4D, no? It's like a first practice. Once we have performed the 3D and we have seen the coronal view, without removing the vaginal proof, we place the patient in semi-supine position. This is not only because the patient will be better, will be more comfortable, it's because you can place better your arm, and with that you are not moving. Because I've seen another groups doing uterine peristalsis and they have a huge problem is you cannot be a stand like this without nothing here, without moving. So this is one of the techniques that we developed in order that we are not moving. Anyway, in sometimes the patient can cough, the patient can, it's obvious. That's why we are assessing 6 minutes, because theoretically one of these minutes cannot be assessed. But anyway, we are recording these 6 minutes. Meanwhile, we are doing the 4D ultrasound. And then we process the video and speed it up 15 times. So here's a video how we are doing that. First, the 3D. Okay. It's like we taught you that this is the sweep, and we see the coronal view. We are confident. Then place the semi-supine position, and this is already the video after we processed it. Okay, and we can see the contractions. All right, so the problem is that we saw in our database that we have already now more than 500 patients recorded, but here we assessed around 250 or 260. Okay, our interest now was that we know the main of our patients with contractions have low progesterone levels, but what happens in the others? So we were looking for another markers to see what's the problem, why this hypercontractility not related with progesterone. And well, this is our last communication in our national congress, and there we saw that we had more contractions in patients that were treated with a substitute cycles and a normal replacement therapy than the natural cycles. Okay, it can be logical because in natural cycles we have higher levels of progesterone, but we adjust the assessment, the analysis with progesterone. So regardless of progesterone levels, we had more contractions in hormonal substitute cycles, in prepared cycles. So it's quite interesting because, you know, it supports the theory that hyperestrogenism can make these contractions. In the same way, we saw that the compaction, it wasn't associated with progesterone levels, but yes, with contractions. So more compacted, less contractions. It was you know, it was surprising, but probably it's because the progesterone levels in blood doesn't reflect whole the progesterone function. And yes, the contractions, and yes, the convection. So we are starting from this point, but it's quite interesting. So our conclusions in our research until now, because we are increasing the patients, is 1.5 contractions per minute could have a detrimental effect in our outcomes. Then 1.5 contractions per minute, it seems associated with less levels of progesterone. Then more contractions have been seen in these substitute cycles in comparison with natural cycles. And the convection, it seems that is a protector effect in contractions. So anyway, we are facing some big problems in that. One is how could we measure the contractions? Then is what is the most important feature to be assessed? The frequency, direction. Okay, we will talk later. And what about the contractility of the whole uterus? So how can be measured? There are 3 ways published. One is counting. I'm doing that. And obviously, it's subjective. You can do this reproducibility studies to see that, and more or less they have a good point, but it's subjective anyway. So it's very interesting, the ultrasound speckle tracking. A Belgium team is working with the engineering university, but it's semi-automatic. The problem is these markers, tracks, are placed manually, and then the machine is analyzing the movements of these marks. What's the problem? They have to see whole time the marks, because everything that is moving these marks is considered like a contraction. So it means that a vowel, a breath, everything is considered as like a contraction. So because I tried to work with them in my 4D ultrasound, but they couldn't. They couldn't because it's too much information and it's more manually than automatic. Anyway, it's quite interesting, but I think we need more. And we have the technology now to do more. And then the elastography, that really I cannot see it. It's published, but you know, it's you can measure the different stiffness between 2 tissues, but you have to select manually the tissues. And where are you selecting here? I don't see the elastography as a way to measure the uterine contractions, to be honest. So then what might be measured? Yes, in the ultrasound tracker market, they can measure all of this, and this is what I want. Is what I want. I want the same. I want to be able to see the frequency, velocity, amplitude, contractions, coordination, and direction. It's true that you can see the direction and coordination more or less, but as I told you, we need more. And then, I'm sorry. Okay, and then I'm obsessed with that, because my problem is I wanted to improve the 2D. Okay, I'm doing 4D. This is amazing. It's not. I'm only assessing one slice of the uterus. Anyway, it's a coronal view, but it's a 2D again. So I don't want it. In my mind is I want to be able to see whole uterus movement, and I want a machine that able to let me know what movements they have, like in a heart. It's already made. This technology is already made. It's not nothing that we cannot do it. So the artificial intelligence is very important here because the human eye is not able to see all the slices of the uterus and differentiate between one of the contractions here is the same like here. So that's why we need the artificial intelligence. And I think we are in the good way. We cannot be stuck in the endometrial thickness. We cannot be stuck, and I'm surprising that we are still in this point. But I think it's very promising, and we will be able to understand more the window of implantation. So this is the bibliography. If you need something, please let me know. And thank you.
Thank you very much, Belen. This was another